Hello, ladies and gentlemen, and thank you for joining us. Today we have with us Dr. Rick Boo from Sims Murphy Clinic. He's a master surgeon who's going to be talking to us about technical nuances for resection of very challenging lesions, and those are the Thalamopeduncular tumors in pediatric patients. With us, and please go ahead.
Thank you, Aaron. I appreciate the invitation to talk about this group of unique tumors to younger children. We've had the occasion to have experience with about a dozen of these tumors over the last few years, and with our newer functional imaging technology, we've learned some lessons in the management of these tumors. This is an interesting group of tumors, and they typically will present with a progressive hemiparesis as the tumors grow from the cerebral peduncle. And as you can see in our group of children here, they typically present in the first decade or decade and a half of life. I've not seen these tumors in older people. These seem to be unique to the younger children. They don't have pain. They typically don't develop hydrocephalus or present with headaches, but they present with progressive spastic hemiparesis. And depending on where the tumor arises in the peduncle, the face may be more involved than the arm may be more involved than the leg. In some children, it's the gait that first brings it to attention, and then the arm gets to be more involved later. Typically, these children may be treated non-surgically or just with a biopsy at first presentation because of the deep location of these tumors. But if you look at the scans that I'll show you in a moment, you'll see that these are focal brainstem tumors, and most of the time they are benign histology, almost always pilocytic. We've had one child in this group whose tumor at biopsy proved to be a diffusely infiltrative low-grade astrocytoma, and we managed him with low-grade chemotherapy and not with resection, given that his histology was infiltrative into the brainstem and basal ganglia. The understanding of these tumors is important. The recognition of them as a distinct group is important, because if you look back through the literature on these tumors, they typically are lumped in with thalamic tumors. Sometimes they're described as tumors of the inferior thalamus. And as surgeons, when people think about thalamic tumors, they tend to like to approach them from a transcallosal approach. With these tumors, they arise from the peduncle underneath the thalamus, and the normal thalamus is pushed up by the tumor. So a transcallosal approach to these would take you through normal thalamus and would be the wrong approach for these tumors. As you can see in our series here, a number of these children were treated with biopsy or partial resection, and then often sent on to chemotherapy given their young age. And when they progressed on chemotherapy, which they all tend to do over time, then that's when they typically get referred into us. So here are some representative pictures of these tumors. Sometimes they enhance, sometimes they don't. If they're good size and they enhance in a heterogeneous fashion, they're often thought to be glioblastomas, and sometimes these children are treated with chemotherapy and radiation without a biopsy, with this mistaken thought that they're malignant brain tumors. As you can see here, they're focal tumors, and typically the normal thalamus is pushed up. So as I mentioned earlier, a transcallosal approach to these tumors would take you through the normal thalamus to get to them. If it's a large tumor like this, that may be a route to get into the tumors, but generally the normal anatomy of the thalamus is so thinned out, there are no accurate planes. So typically neurosurgeons have described more inferior approaches to these tumors. In the paper by Tad Tomita, he described 7 of these children that he treated, and typically they were approached from a subtemporal approach. In some children, the tumors may arise higher up in the brainstem, and